Hello, and thanks for joining us today for the latest The Scientist webinar. My name is Iris Klobatsky, Associate Editor, and I'm here to moderate today's event. I'm very pleased to introduce our speaker, Mushfique Alam, who will be presenting today's talk, Predicting Chemotherapy Response with Patient-Derived Gastric Cancer Organoids. Mushfique Alam is a surgical registrar in general and upper gastrointestinal surgery at the University Hospitals of Liverpool Group in the UK. His clinical and academic work focuses on esophagogastric cancers, particularly using multimodal approaches to support personalized therapies. His postdoctoral research explored patient-derived organoids as predictors of response to neoadjuvant chemotherapy in gastric adenocarcinoma. He has received several prestigious grants, including the Sir Alan Parkes Research Fellowship and the Royal College of Surgeons of England, and funding from UK Research and Innovation. A very warm welcome to you, Mushfique. Following the presentation, we will have a Q&A session, and we welcome any questions you may have. Please ask questions using the Q&A system to the side of the live stream player. And without further ado, I will now hand over to Mushfique to begin his talk.
Thank you very much for the invitation. My name is Mushfique Alam. I'm a general and upper GI surgical trainee based in Liverpool, a Royal College of Surgeons of England Research Fellow, and a PhD candidate at the University of Liverpool. Today, I'll discuss our work using patient-derived gastric cancer organoids to study the chemotherapy response in patients with gastric adenocarcinoma and how dynamic imaging has helped us go beyond conventional endpoint assays. To set the scene, I guess I'll start with telling you a little bit more about myself. So I come at this primarily from the clinical side. I'm a surgeon by training. My day job involves operating on and looking after patients at the Royal Liverpool Hospital, pictured here in the top left-hand side of your screen. If you haven't heard of Liverpool before, it's a city in the northwest of England, perhaps most famous for being the hometown of a little-known band called the Beatles, and if you're into sport, soccer in particular, Liverpool Football Club. The rest of my time is spent in academia and in research at the University of Liverpool. Now, my personal academic interests are in gastroesophageal malignancies, particularly gastric cancer, and our research group, who you can see here in the top right hand of your screen, are involved in a number of clinical, basic science and translational projects, which are all basically aimed at improving outcomes from gastric cancer in our region. So, why gastric cancer, you may ask? Well, to provide some context, I'm going to start the way I start most of my days, and that's with the story of a patient. A patient who was a 71-year-old female who was diagnosed and staged with the T3N0M0 distal gastric adenocarcinoma. Now, in the UK, gastric cancer still accounts for 18 new cancer diagnoses and 12 cases of cancer-related mortality on a daily basis. Now, unfortunately, the Liverpool City region where I'm based is a high-risk area and has an incidence and mortality rate that is significantly higher than the rest of the country. Now, the gold standard curative treatment in the United Kingdom, and indeed most of Europe, is neoadjuvant chemotherapy which is given prior to any operative intervention. Now, the combination chemotherapy regimen known as FLOT, which is a triplet regimen containing 5-fluorouracil, oxaliplatin, and docetaxel, is the regimen of choice. And this was established by the landmark FLOT4 AIO trial. So this patient went on to complete the gold standard of 4 cycles of their neoadjuvant FLOT at the full dose, and then progressed through their journey to a planned surgical resection. Now, unfortunately, on table, she was found to have metastatic disease despite receiving gold standard treatment up to date. And this effectively meant that she negated a curative resection and had to be transferred for ongoing palliative treatment. Now, I'd love to tell you that this is a rare occurrence, but unfortunately, a significant proportion of patients demonstrate little or no response to their chemotherapy, and only a minority of patients demonstrate the rare complete response. Now, this is something that is consistent throughout the FLOT-treated populations from different centres throughout the world, and essentially means that there are some patients who undergo ineffective chemotherapy and progress through their treatment to the point where curative surgery is no longer possible, such as in this unfortunate case, or recur early following what is fairly radical surgery. So this brings us to the central problem. At present, we do not have a model that can accurately predict the chemotherapy response prior to treatment being commenced, and therefore are unable to identify patients who would truly benefit from chemotherapy versus those patients in whom it would be futile. There are, of course, several models available in translational cancer research which have been used to explore this field further. Within the spectrum of disease models, two-dimensional cell lines remain commonly used as they are accessible, scalable, but often oversimplify biology. At the other end, patient-derived xenografts may preserve more tumor biology. They're expensive, slow, and not practical if the aim is to inform treatment in clinically meaningful timeframes. So what our group wanted was a pre-treatment platform that was patient-specific, biologically relevant, and functionally informative within a realistic experimental turnaround time. And this is what led us to patient-derived organoids. In brief, patient-derived organoids are patient-specific three-dimensional cell aggregates which recapitulate the tissue of origin in culture, and in our group's opinion, provided a useful compromise between biological relevance and practical usability. So this is the basic workflow that we use. We take a pre-treatment biopsy or a post-treatment surgical resection sample from the patient. We then break the tissue down using a combination of mechanical and enzymatic techniques to generate groups of gastric epithelial units such as crypts and glands, which we then spin down. We then collect this mixture and seed it in a three-dimensional matrix. Now our group uses Matrigel at present, but we've also used Ultimatrix in the past for both our human and murine organ modelling. Once expanded to the sufficient model, these organoids are then exposed to a range of flock doses. We then assess the in vitro response through a commercially available endpoint viability assay that is based on luminescence and uses the concentration of ATP within the culture as a surrogate marker of viability. The luminescence reading is then converted to a percentage viability readout, which is then used to generate dose-response curves. We then take the dose-response curves and compare the metrics derived from the dose-response curves to the patient's eventual in vivo pathological response as assessed by the final histopathological analysis of the resected specimen. So in essence, our core question was, can a pre-treatment organoid model recapitulate or at least meaningfully reflect the patient's tumor chemotherapy response? That was the translational hypothesis underpinning the whole project. Our early data was very promising. Here you can see an example of two dose-response curves generated by two different organoids taken from patients that had tumors that were from the opposing spectrums of the pathological response scale, otherwise known as the Mandard grade. Now for reference, Mandard grade of 2 is a tumor that has shown a good response to chemotherapy, whilst a Mandard grade of 5 signifies a tumor with no response. Now encouragingly, we found the dose-response curve generated from an organoid derived from a tumor that was responsive, shown here as the green curve, was significantly different in its fit relative to the curve derived from an organoid taken from a tumor that was non-responsive, shown here as the curve in red. This suggested that organoids can indeed be differentiated on the basis of their chemotherapy sensitivity. This pattern actually continued with an expanded cohort. You can see here a set of dose-response curves from a number of patient-derived gastric cancer organoids that have been separated into those derived from responsive tumors, which are graph A, or on the left of your screen, and those derived from non-responsive tumors, which are shown in the graph B, or on the right of your screen. Now, on the whole, organoids taken from responsive patients generated dose-response curves that were shifted more to the left, relative to dose-response curves generated from organoids derived from patients that were non-responsive to chemotherapy. And this visual difference that you can see here between the two graphs was indeed statistically significant. Overall, this was an important first finding, and from a translational perspective, allowed us to cross that very first hurdle. Could the model and experimental design distinguish one patient's tumor biology from another? Our data suggested that it could. So whilst the visual aids provided by the dose-response curves were helpful, they required some further quantification. We did this using the area under the curve. When comparing the median area under the curve from responder and non-responder derived organoids, we found a statistically significant difference. telling us that the organoid response is not just visually interesting, it appears to have a discriminatory value. This is what you can see on this graph here. The median area under the curve in responders was 268.6, whilst the median area under the curve in non-responders was just over 300, so that this difference was statistically significant with a p-value of 0.3. Now, this was probably the most encouraging summary statistic from the early data. Using the area under the curve, we performed a receiver operative characteristic, or ROC analysis, which is what you can see on the right-hand side here. Now, this showed an overall area under the ROC curve of 0.8. To put that into context for a clinical test, that would suggest that there was moderate to good discrimination of our model in differentiating a responsive versus non-responsive organoid, and therefore patient. Now, of course, this is preliminary work, and you'll notice that the confidence intervals are fairly wide, and this tells us that larger numbers were needed along with external validation of our chosen threshold. However, as a proof of principle, this was indeed promising, and suggested that patient-derived gastric cancer organoids may indeed be capable of distinguishing between patients who are responsive and those who are unresponsive to gold standard neoadjuvant chemotherapy. Perhaps unsurprising to the scientists amongst the audience, I discovered that you never truly complete in science, but rather you open doors which lead to more doors and so forth. So to that end, I realized through my experiences that although our results were indeed promising, they demonstrated some of the very real limitations of our current methodology. What we were largely doing here is compressing a complex, dynamic biological process into a single summary output through an endpoint assay. No doubt that gave us useful information, absolutely, but it did not tell us much about response kinetics, morphological differences, the heterogeneity within the culture, and the presence of acquired resistance through repeated exposure to chemotherapy, to name but a few examples. Furthermore, for those of you who are working within the organoid field, you'll know that reproducibility between lab and lab groups has been a real issue. There's significant heterogeneity in the methodology and output between labs, which make comparisons fairly difficult. These factors motivated us to look for platforms that would facilitate more dynamic assessments of our model and perhaps corroborate our preliminary results and look for a reproducible method that could facilitate higher throughput sensitivity testing. This is what led us to dynamic imaging and utilizing the OmniImaging platform. Now, perhaps like most of good science, the initial encounter with this platform was actually rather fortuitous, as I'd rather serendipitously encountered the 12-plate variant, the OmniPro 12, whilst having a chat with one of my colleagues in another lab in our institute, who just so happened to own one of these. This is essentially an incubator-compatible live cell imaging platform, which perhaps most advantageous to our group, had an organoid-specific analysis module, which we utilized to observe organoids repeatedly over time in a more automated and reproducible manner. For me personally, that was one of the immediate practical advantages, automation. Rather than occasionally taking snapshots manually, what we were able to do is image organoids at regular, predefined intervals and generate sequential visual records of how they changed over time. And this is what you can see on the left-hand side of your screen. As you can imagine, this saved a considerable amount of time and reduced the manpower involved in repeated monitoring. Beyond convenience, it also gave us something biologically useful and confirmed that morphology itself can carry useful information. One of the first things we were able to do is visualize the differences in morphology between organoids derived from malignant tissue and organoids derived from non-malignant tissue. This is something that you can see in the center of your screen. If you notice, the cancer organoids in the left-hand side of your screen are more irregular in shape and seem to have a darker lumen in the middle and often don't appear as large as the non-cancerous organoids, which you can see on the right. The non-cancerous organoids, or normal organoids if you like, are more classical in their organoid shape in that they're perhaps what you would associate with an organoid, being more spherical and having a clear lumen. Now, this is something we also recapitulated on H&E staining of the organoids, and this follows the histological differences between the regular tissue architecture of the non-malignant gastric epithelia, which you can see in the top right of your screen, and that of the irregular characteristics of the cancerous epithelium, which you can see on the top left of your screen. Perhaps more interestingly, someone who deals with cancer more regularly, we found that these cancer organoids appear to recapitulate the known histological variation of gastric cancer. For those of you from a non-clinical background, gastric cancer can be divided into 3 subtypes on the basis of their histology. These are called the Lawrence subtypes and include an intestinal subtype, a diffuse subtype, and a mixed subtype. What you can see on this slide is that the 3 different types of histological subtype resulted in organoids that were morphologically different from each other. So in the top left of your screen, you can see organoids derived from an intestinal subtype of gastric cancer, and these tended to more closely resemble normal organoids with clear spherical shape and a clear lumen. And this was recapitulated on H&E analysis as well. Diffuse type cancer organoids were more irregular in shape and didn't have a clear lumen and seemed to have a darker center or a dense lumen. And again, this is something we saw when we looked at these after staining them with H&E. The mixed type cancer organoids tended to be a mix of the former 2. Now that's quite encouraging because it suggests that the platform is preserving biologically and clinically meaningful diversity rather than just flattening it out. The second major advantage was the built-in organoid analysis module. Using user-defined set gating parameters, we were able to quantify organoid counts in a more standardized and automated way. Now that became useful for several reasons. Firstly, as can be seen in the graphs on the left, it allowed us to chart organoid growth over time, including prior to treatment, which meant we could better understand baseline growth kinetics. Secondly, it helps control for the number of organoids present in each well at the start of an experiment. This meant that comparisons were more like for like from the outset. And that's fairly important because one of the recurring challenges in organoid work is there is significant heterogeneity and variability at baseline. If one well starts with substantially more organoids than another, you can imagine that interpretation of an endpoint assay becomes more difficult. By using count data up front, we could better normalize and standardize the experimental setup. So essentially, the count was not just a readout after treatment, it also helped us improve experimental control prior to treatment. The Omni therefore made it simple for our lab to collect this longitudinal data, and for someone who's a visual learner like me, automatically compile it into these time-lapse videos, which you can see here. Now, once we have the longitudinal count data, we can assess whether change in organoid count tracked with the patterns observed on the dose-response curves. In other words, if a sample appeared sensitive using a conventional endpoint readout, did the count-based behavior show the same pattern? This gave us a second dynamic way of interrogating response. As you can see in this example, the change in counts relative to baseline did indeed change in association with increased doses of chemotherapy and reassuringly demonstrated different magnitudes of reduction in association with escalating doses of chemotherapy between non-responder and responder organoids. The next feature we became interested in was darkness. Now, this really came from the repeated morphological observation that as we monitored treated organoids over time, they appeared to get optically darker or denser in a way that seemed to track with treatment effect. Now that raised the question of whether this was something we could move beyond qualitative observation and actually quantify into a readout. So in collaboration with the Axion team, we developed the darkness ratio. And what this slide essentially shows is that by using the select gating parameters, here we used roundness to identify something positively as an organoid, you could develop a ratio of dark organoids to light organoids by changing the threshold of pixel density that you wanted the module to detect. Based on this, we developed a ratio that worked for our module and could capture this feature in a more objective way. This was immediately attractive because it potentially captured something biologically meaningful rather than just providing something that was visually striking. So the darkness ratio therefore emerged first from observation and then from quantification. And this way we were able to formalize a phenotypic change that to us seemed relevant. So what you see here is that the change in the darkness ratio at 72 hours following treatment with a range of FLOT chemotherapy does indeed increase across both responsive and non-responsive organoids with increasing doses of treatment. However, what you can see is that there appears to be a greater increase in the responder-derived organoids, particularly at the higher doses of FLOT. Now, this difference did not achieve statistical significance, so I'd be perhaps cautious not to overstate it, but the trend itself was encouraging and gave us a reason to explore this metric further. One of the possible explanations for this lack of a strong statistical significance, perhaps the histological heterogeneity of gastric cancer and how that's reflected in the morphology of derived organoids. Now, if you recall from the previous slide, the intestinal subtype organoids are typically more concentric and have this clearer lumen. And as you can imagine, using a darkness ratio is possibly better suited to this subtype, as any changes induced by chemotherapy that involve increase in pixels or increase in darkness is clearly better detected. In contrast, the diffuse or mixed subtype organoids were often more regular and already had a dense dark center or lumen, which means that in that setting, picking up a further change in darkness becomes harder using this metric alone. And I think that's exactly what these graphs illustrate. The intestinal subtype, which you can see in the top left-hand side of your screen, shows a more convincing pattern in increasing in the darkness ratio in response to higher doses of FLOT, whereas organoids that are mixed or diffuse, as can be seen in the bottom left-hand side of your screen, show much greater variability and don't appear to show as high of an increase in the darkness ratio relative to those that are intestinal subtype. Of interest in the graph at the bottom left, you'll see that two organoid lines seem to be fairly different from the other three in that they show a response at the highest dose, which is significantly higher. Now, of interest, both of these organoid lines were actually taken from a mixed subtype cancer, which suggests that there may be an element of response here that is detected on the basis of having a significant proportion of intestinal subtype organoids within that culture. Now, that's not only of scientific interest, but actually follows what we know about gastric cancer biology. We know that diffuse-type gastric cancer, on the whole, has a worse prognosis, and these patients tend to respond less well to their chemotherapy, while intestinal subtype cancers tend to do better and, on the whole, have a better response to neoadjuvant chemotherapy. And as such, it may well be that the darkness ratio provides a metric that actually confirms what we already know to be true from gastric cancer biology. So rather than seeing this as a negative, we saw it as a clue that morphology-derived metrics may indeed be interpreted in the context of organoid subtype and baseline architecture. And actually, that's fairly advantageous, and at present we're working on further assessments of morphology to see if the mixed subtype organoids can be differentiated into an intestinal predominant or a diffuse predominant culture, and whether the predomination of one subtype over another translates to any significant differences in the chemotherapy response. So, where does all of that leave us? Well, my view is that these imaging-derived metrics are valuable, but still best viewed as complementary rather than substitutive present. Endpoint assays still provide an important quantitative benchmark, and it's still the gold standard that we use in our group. We know that they're well established, they're relatively robust, and they're fairly straightforward to interpret within a conventional response framework. But what the imaging is adding is further depth and, of course, automation. It's adding dimensionality, longitudinal monitoring, kinetic information, and as hopefully you've seen, morphology-based phenotyping that endpoint assays just can't do alone. So at this stage, I would not claim that count and darkness replace an endpoint assay at all, but rather that they enhance the overall functional picture. Used together, these approaches are more powerful than either on its own, and this synergy is where our ongoing work with Axion is heading. The longer-term goal is not simply to generate more images or metrics, but rather to develop a multimodal, functional platform that allows for a standardized method of response assessment between different lab groups and one that integrates different layers of information in an automated, reproducible, and bias-controlled way. And ultimately, I think AI and machine learning will be important here. The more information the system gets, the better it will become at differentiating between organoids, organoid subtypes, and subtype-associated response. So in my view, the future direction is a platform that's not only richer biologically, but also scalable, standardized, and clinically meaningful. The real ambition ultimately is translational. If we can generate automated, reproducible, and ultimately functional readouts from these patient-derived organoids, then this kind of platform may one day serve as an adjunct in real-time clinical decision-making. Now, I'm careful to use the word adjunct here at present rather than replacement, but you can imagine a world where if such a system could provide robust, bias-controlled metrics within a clinically relevant time frame, then it could potentially complement pathology, imaging, and any molecular data that may be available when assessing the likely treatment response. Now, this still remains a future goal rather than a present reality, but I think it is one that's realistic and definitely a worthwhile direction to pursue. And from my perspective as a clinician, that's what really makes this work exciting. So, hopefully, in conclusion, I've been able to convey to you that patient-derived gastric cancer organoids are indeed a promising translational model for assessing the chemotherapy response. I hope that we're able to demonstrate that conventional endpoint assays, although are useful and have given us a predictive signal, they don't capture the full dynamics of the treatment response within this model. Thirdly, dynamic imaging using the OmniPro 12 has great potential and has allowed our group to automate serial morphological monitoring, quantify organoid count, and now assess growth kinetics and develop morphology-linked metrics such as the darkness ratio. And finally, while these image-derived features are not yet a replacement for endpoint assays, I believe they represent an important building block towards a multimodal functional platform that could, I hope in time, provide clinically relevant adjunctive information. Thank you all very much for tuning in, and I look forward to taking your questions.
Thank you very much, Mushfique, for that wonderfully informative presentation. We really appreciate you sharing your expertise with us today. I'm now going to move into the Q&A session. To submit a question for our speaker, please enter your question into the box to the side of the live stream player and click send. We will answer as many questions as possible during the time available. I can see we already have some questions coming in, so I will move right into those. The first question we have, given the promise of patient-derived organoids for modeling tumor heterogeneity and drug response, what do you see as the biggest remaining challenge or next steps needed to translate this into the in vitro findings into clinically actionable personalized treatment strategies?
Can everyone hear me all right? Firstly, thank you very much. That was very kind of you. I'd like to apologize to everyone first, actually. I was very nasal during that recording. So that's not usually how I sound. So sorry if I came across difficult to understand. With regards to the question, so not specific to this platform, but more generic to organoid-based work on the whole, the main issue really is reproducibility between laboratories and groups. So to really have a platform that can give you something meaningful that is translatable between one group to the next or one patient cohort to the next, you need a test that is reproducible, that gives you consistent results, that is biologically meaningful. And so the main issue really is the fact that organoids as a model themselves are so inherently variable due to the plethora of factors, such as the media, the conditions, the tissue of origin, and the protocols used by the scientists. And that's really where some of the work we were doing together with Axion is heading. So we're obviously looking at assessing response and response metrics. And the whole point of using something that is AI-based and is based on a machine is to eliminate some of the steps that essentially introduce differences in response assessment. The second part of that is, as the question rightly states, I guess organoids at the moment, certainly the model I was using, was predominantly epithelial based. And for those of you listening who may be cancer scientists or work with cancer, know that obviously cancer is a biologically complex thing. It's not just epithelial cells, adenocarcinoma, which is what I work with. But within that, there are microenvironment cells, immune cells, and other constituents. And whilst my model at the moment doesn't include that, there is good evidence and good work being done by other groups that co-culture models are being developed that recapitulate some of that with more fidelity. So as the model sort of develops and the expertise develops, I suspect we will be able to make the next steps and overcome some of those limitations.
Thank you. Our next question, as both a clinician and a scientist, how has your work with organoid-based in vitro studies influenced how you think about future patient care or treatment decisions?
So this is quite interesting, actually. One of the shifts in my thinking paradigm really has been, as someone who is clinical, we're often obviously informed by big randomized control trials on the treatment that we offer to our patients. And as I started doing this more and seeing more and more patients in clinic, I started to have that realization that although medicine or drugs themselves and these trials deal with populations, me as a surgeon, I actually deal with people. I'm dealing with a person sat in front of me. And although on a population basis, the chemotherapy regime here, FLOT, works very, very well and is significantly better than what we used to do before, I have no guarantees of it working for the person sat in front of me. And what I found is, by extension, I was offering treatment in hope rather than in expectation. And that's basically what led to all of this and sort of became the backbone of all of this. And working with all of this has really cemented that attitude that we have to move away from population-based management and move more towards personalized management. And that's actually one of the National Health Service's targets going forward anyway.
Thank you. Next question we have is, do you envision expanding this platform to other cancer types? And if so, have you considered what other types might be good candidates?
We have indeed. In fact, so my PhD was done in Professor Mark Pritchard and Dr. Carrie Duckworth's organoid laboratory in the University of Liverpool, and they've actually got extensive experience in organoids outside of gastric. The gastric was particularly my area of interest, but they've got interest in growing neuroendocrine tumor organoids, colonic organoids, and small bowel organoids as well, both from human and in mice. One particular avenue that we're exploring actively is colorectal cancer organoids, and we've done some work in pancreatic cancer organoids, PDACs, as well. Again, predominantly epithelial-based cancers, and looking at similar things with regards to assessing response to therapy. So yes, there are plans to branch out into more sort of confined to GI, given that's our expertise, but other types of organoids as well.
Thank you. We have a question about the dose response curves. Did you evaluate the effect of 5-FU alone or the FLOT combination on the organoid's viability? And if in combination, did you vary all the drug concentrations or only the 5-FU concentration?
So yes, we did. So obviously too broad for the purposes of a seminar, but we actually validated that as single doses of the constituents of FLOT across a range of concentrations. So we did 5-FU, leucovorin, oxaliplatin, and docetaxel individually, initially in our murine gastric organoids, and then in healthy human, so non-cancer patient gastric mucosa-derived organoids, and then finally in patient-derived organoids. And then we went to combination FLOT together. And then with combination FLOT, indeed, as per any sort of pharmacological experiment, we had 10 different dose points. So starting from control to suprapharmacological toxic doses, we had a whole range of doses where we changed the combination and the concentration of each drug.
Thank you. Our next question is, a challenging point when establishing cancer organoids is the composition of the culture medium. Can you please comment on which components you added to the culture medium?
Well, so without giving any secrets away, yes, we have the standard Wnt conditioned media, which we grew in-house with the LWRN cell line, which then produced the Wnt, the noggin, and the spondin required for organoid generation. That's publicly available from all the protocols. And then diluted that with a DMEM F12 plus Glutamax base. And then to that added the different growth factors that are specific to the gastric cancer epithelial niche and the stem cell that's responsible for driving organoid generation and maintenance in the gastric cancer niche, which is the LGR5 positive stem cell. So those are things like fibroblast growth factor, epithelial growth factor, and other small molecules that we basically titrated to shift the differentiation status and the status of the culture on the whole to be more representative of a gastric adenocarcinoma.
Thank you. Our next question is, would organoids allow researchers to test the impact of the microbiome? For example, the presence of Fusobacterium nucleatum in the tumor microenvironment.
So that's an interesting question. So inherently, as the model as I've used it, no. But one of our colleagues in the lab did work with co-cultures and injections, and sort of the bacteria that we used most was Helicobacter pylori or Helicobacter felis. So you can develop systems where you can co-culture the organoids with certain bacteria. Whether those are the same bacteria that are in the microbiome, I don't know of any direct evidence, but there is evidence to suggest that you can modulate the organoid module, the organoid model, into a 2D monolayer, which then makes it easier to co-culture with certain pathogens. And so theoretically, yes, you could indeed assess the effect of certain components of the microbiome by adding them to the media or removing them, although I personally don't have any experience in that.
Thank you. Our next question, can you please elaborate on the OmniPro potential upgrades that can help with the organoid modeling and studies?
Yeah, so a couple of things that we're, again, without giving too much away on behalf of Axion, a couple of things we're working on. Obviously, we've seen the darkness already, and their analysis module already will do roundness, will do area, and then we'll do a count. One of the things I've found would be quite useful, and those of you who may have worked with organoids or indeed cell cultures may know that there is no guarantee that your cultures mature at the same time or reach the stage to be ready for experimentation at the same time. So one of the things we have to do, especially with gastric cancer organoids, is monitor them regularly. And so what that means is in a 96 well plate with 96 different conditions, let's say, within that well, there's a high amount of variability of the status and the morphology and the readiness, if you like, of each well to be experimented on. And that's something at present that needs to be done manually. But together with Axion, we may be able to build a system where actually the AI and the analysis and the scanning will scan your whole plate, and you may be able to set a preset target where you want, let's say, 75% of your wells to reach a confluency or roundness or an area of an amount you set or a darkness of an amount you set, and then it will automatically tell you or give you an email to say, okay, we think based on your parameters you're ready to be experimentally commence experimentation. And that's really important because effectively that means over the course of 20, 30, 40 different patients and 5th, 6th, 7th biological repeats and technical repeats that you're comparing like for like in regards to morphology and count, and not just going blindly on day 3, I'm going to do an experiment, which is often, and certainly not just everyone, other groups, but what I started doing as well. But then I found that the validity and the comparisons weren't really accurate. So that's one that we're working on actively, with a couple of other things following on from the darkness that hopefully we'll see will come to fruition.
Thank you. Our next question, do you have experience with apical out organoids or air-liquid interface systems? Do you think either of these would have utility in understanding or predicting chemotherapy responses? So
I'll take the second part first. Yes, absolutely. I think they will have utility. Do I have personal experience? No. There was a PhD student again in one of our adjacent labs who worked in animal organoids and looked at the apical out transformation. But again, from my perspective, that wasn't something I personally dabbled in. But from reading the literature and going to seminars and talking to people, I think there's a group in Oxford, the University of Oxford, that are sort of looking into this sort of thing in gastric organoids, and they've found some very fruitful results. So yes, theoretically, I think, yes, there's definitely scope to incorporate those things, but I personally, unfortunately, don't have experience in that.
Thank you. Our next question, how would you compare PDO to organoids derived from cancer stem cells or other types as an in vitro model for drug screening? Which is the best for clinical significance or experimental reproducibility?
So sorry, how would I compare PDOs to?
To organoids derived from cancer stem cells and other types as an in vitro model for drug screening.
Right. So doing what we've done as a group obviously requires access to patients. And that, I guess that's the difficulty. You have to be in a university center. You have to have ethical approval. And obviously, yeah, the best model is always going to be the one that you can directly take from the patient. But you're going to have to balance that with the accessibility, the cost. Now, I'm quite fortunate. I work in a nationalized health system. I am the UNITS research fellow. I was doing a PhD in the institute attached to our hospital, and literally my laboratory where we used to work and our operating room and theatre in the hospital is a 5-minute walk from across the road. So that made sense for me in that I was getting the best, I guess, that I could. With that in mind, not everyone can be so fortunate. So if you had to come to a pragmatic sort of second line, then of course using cancer stem cells and then giving them the right niche factors to modulate them and stimulate them to become more cancer-like is a good second option. That being said, we know particularly for gastric cancers that the heterogeneity is vast. We know that there's heterogeneity between cancers within the stomach. We know that even within patients of the same cancer within the same sort of area, there's heterogeneity. And a level above that, we know that there's heterogeneity within the same cancer in that they're fairly polyclonal. And that's probably one of the contributors to the variable response to the gold standard chemotherapy that we see, which is why in that context, getting multi-site biopsies and deriving organoids from patient tissue, I think, will still be the gold standard and the best option.
Thank you. Our next question, what is the typical time frame needed for patient-derived primary cells to develop into fully formed organoids under standard culture conditions before the drug treatment can begin? And does this differ from patient to patient?
Absolutely. That's an excellent question, because if you think about actually translating this into something that can help the patients that we see, you realistically want results by the time the patient will start therapy. I don't know in other healthcare systems, but within the national healthcare system here in the United Kingdom, there's a timer. So by the time the patient gets diagnosed, you have to see them within a pretty rapid state. They usually get their diagnosis within 2 weeks. You see them in clinic and you start chemotherapy, if they're fit, after a discussion at a big meeting, pretty rapidly. Now, for my purposes, in a laboratory, whilst I was doing my PhD with a single operator, it took me longer than that. Sometimes it took me up to a month just to get enough to do my first experiment. However, we've now been fortunate to be funded by Northwest Cancer Research into becoming the North of England's first ever organoid hub. So we now have an infrastructure and an actual scientist rather than a surgeon playing scientist who is dedicated to doing just that, to growing organoids, to banking organoids. And so we now have the infrastructure and the technical support to do it. As I got more experienced at it, I was able to cut down the time significantly. And some of the things that influenced that, number one, and most importantly, I guess, was the amount of tissue I was able to acquire at the start. So invariably, if you only take some small biopsies and get a little amount of tissue, the organoid generation is difficult. And to passage them to do enough experiments to scientific rigor is difficult. As I got more mature and realized how much tissue we need, this improved with greater yields from the biopsy. The techniques also improved. My handling of the tissue and the organoids also improved. So there was a positive learning curve in that I was able to reduce that to less than 4 weeks for the first experiment. Now, given that this was a proof of concept, we obviously needed to do everything to scientific rigor. So I repeated everything per patient 3 times in different passages with 3 to 5 technical repeats per experiment. And again, bringing this back to Axion, one of the reasons why we want to build a platform like this is because I want to be able to validate a system where it's so accurate and so well validated internally and externally that it gives you the results and facilitates giving you rapid results without having to do so many replicates. And so what essentially happens is it mimics sort of like a blood test. For those of you that are clinically trained, it becomes like doing a full blood count or a CRP. Now, in a patient, you don't take the blood 3 times and do 3 technical repeats to get their average CRP value. You just do it once. And so with greater infrastructure support, greater experience, and as the model itself develops, I suspect that the time to get valid results out to influence patient decision-making will shorten significantly.
Thank you. And we have a question here about image analysis. We have an audience member wondering whether the pictures are being analyzed in 2D or 3D Z-stack.
So from my understanding from speaking to the software people at Axion, it is 2-dimensional at the moment. It doesn't do 3-dimensional Z-stack, although if I'm mistaken, I'm sure one of the engineers will pop up and correct me. But my understanding is that it is 2-dimensional.
Thank you. We have time for just a couple more questions. What steps do you think are necessary to create a standardized cross-institutional protocol for organoid drug response testing?
Again, that's an excellent question. So I think there's multiple steps to this. I think the first step should be standardization of the media. So different groups use different constituents of the media. Some use commercially available Wnt. As I mentioned, we use in-house Wnt that we culture ourselves using the LWR cell line. Not every published paper give you an exact concentration of the Wnt, the spondin, the noggin that they use. They'll give you some proportions, 70-30 LWRN to DMEM, 90% to 10%, etc. And the exact concentration of some of the micromolecules differ. The ROC inhibitor, the EGF, the FGF that I mentioned, all differ. So I think the first thing to do is to build a media and a constituents of media that is open, that is accessible, and that is consistent between people doing the same type of experiments. The second method is to then develop a standardized protocol of how you're going to exactly assess the response. Now, some people use one assay. I use a very specific assay that's built for 3D cultures that uses ATP. Other people use an MTT assay. Some people use immunofluorescence. Other people have used immunohistochemistry. They're all different ways, but we need to have a standardized way so that all the different groups are comparing the response the same way. And the third one is what we're doing with Axion, which is to take the human and the experimental thing out of it and to let a machine that can take accurate pictures and then basically teaches itself what you want as per set gating parameters to then repeatedly learn based on the data you feed it and to produce results that become as good as the gold standard assays or immunohistochemistry that we use, where if everyone has access to the same machine, then they're effectively comparing like for like and apples with apples and oranges with oranges, rather than everyone using different metrics and different thresholds.
Thank you. And we have time for one last question. Realistically, how far are we from a world where a patient's pretreatment biopsy is routinely used to generate personalized organoids for response testing before chemotherapy?
If I'm honest with you, I suspect I'll spend most of my career doing this. Because translating something to clinical practice is a multi-step process. We've just started to scratch the surface with this model. And even if it's internally validated, you then need massive numbers and corroboration between different groups. So there's a group in Heidelberg that's done something similar. People in Utrecht and Cleavers' group have done something similar. There's groups in the East that have done something similar, and indeed in the United States. So we all need to really sit together at one of the organoid meetings and think about how we can pool our data so that the validity of this model increases. After that, there's multiple sort of caveats to things. It's then getting the approval to then establish this into a clinical pipeline, which is a whole other sort of ball game and is incorporating multiple steps that are required to get that accepted, especially in a nationalized health service. Because what you don't want is a bit of a postcode lottery where one area of the country offers one service and the rest doesn't. That's just not really equitable or palatable in a nationalized health service. And then finally, I guess you need to show that what you're doing will in fact change management, and changing management based on the patient derived organoids is actually benefiting the patients. So then you're talking about then implementing it into a trial and then stratifying treatment based on the organoids in a trial, analyzing that trial, and then that trial's results being disseminated and being accepted by healthcare systems. So realistically, we're looking at years.
Thank you very much again, Mushfique, for joining us today. Unfortunately, that's all the time we have available, but any questions we didn't manage to get to will be answered offline as soon as possible. The webinar will now be made available on demand, and you can access the recording using the same link you used today. We'll also make sure any questions submitted on demand are passed along. A certificate of attendance will also be sent by email to everyone who attended today's session. That just leaves me again to say thank you to our speaker, Mushfique Alam, and to everyone in the audience. See you again soon.
Thank you very much.